So thank you for joining us for today's webinar on transforming patient care, patient and community engagement in an era of evidence-based healthcare. I'm pleased to introduce Dr. Beverly Shea, who has been involved in transforming patient care.
Hi, everyone. Can you hear me?
Dr. Shea, oops, I guess I should have not moved from your picture yet. Dr. Shea is a clinical scientist at the Bruyès Research Institute. She's senior methodologist at the Ottawa Health Research Institute and adjunct professor at the Department of Epidemiology and Community Medicine at the University of Ottawa. She has been involved in the production of more than 40 systematic reviews and is an editor for the Cochrane Musculoskeletal Review Group and also the co-convener for the Cochrane Non-Randomized Methods Working Group. One focus of her work over the years has been on patient engagement in healthcare decisions by involving patients in building relationships, co-designing and sharing responsibility for input with research teams and healthcare professionals. Today, Dr. Shea will provide some background, share her experience, and examples of recent projects that she has been part of. So Dr. Shea, I will now turn the presentation over to you.
Great. Thank you, Eileen. Welcome, everyone. Hopefully that's clear and that you can't hear my seasonal cold too much. So thank you for the nice introduction. Eileen is that an echo? I'm hearing an echo.
That sounds good.
Okay, great. So I thought we'd just start. There's a couple of components to my presentation, and like Eileen said, thanks very much for indicating that I like to have questions as we go along. So feel free to interrupt me or to write in the chat box, and I can answer them so that we don't hopefully lose the interest, or that if there's questions that I can address along the way, that'd be great. Thanks for listening. The plan of the presentation today, I wanted to go through something that we've developed over the last few years, our AmStar. Not sure if everyone on the call today has heard of AmStar or has used it before, but we've had some sort of exciting work and development work over the last year to move it into the non-randomized world. So I would like to go through that with you. And also, to, as Eileen mentioned, to sort of give you some of the methods development work and new innovative things that are happening in patient engagement, particularly around in evidence-based and patient-centered care. So without further ado, as I say, I'm going to focus a little bit around seniors because the work that I've been doing at Bruyès Research Institute and Bruyère Continuing Care has a little bit to do with involving seniors in that, and you'll see from some of the further slides down the road there that we discussed. So everyone knows this statistic now. I'm sure you've heard it on the news a few times about how the number of seniors is a huge number by 2026, 10.9 million. That's a lot in Canada. So we have to be prepared and work closely with our seniors to kind of change the scope of research in the next little while. And one of the things that we found, and you probably know that as well, that seniors, particularly those over 75, are not often recruited into clinical trials. So somehow we have to figure out what the best evidence available is and start to develop trials that include seniors. But for the moment, we would be using systematic reviews. And if they're not involved in trials, they're going to be involved in trials of non-randomized studies. So we want to look at, it's important for assessing the benefits and harms of interventions in the elderly, but we want to look at the best literature and figure out how, for policy and practice, how we may be able to use non-randomized studies of interventions and what, at the moment, it's our only practical option. So what do we do with that? So AmStar and critical appraisal come together nicely. And so most of you know that critical appraisal, some people have sort of been doing critical appraisal over the years, but critical appraisal is basically an explicit, transparent method to judge the internal validity, reporting standards, conclusion, and generalizability. Some people will have use the risk of bias, or a lot of people, for the randomized controlled trials, the Cochrane risk of bias tool. That's kind of been well developed over the years and well used, I think. But there are new instruments that people would have heard of on risk of bias, like the Acrobat, which is now changed to Robbins because of the trademark of the Acrobat name. So that's known as Robbins, and Robbins is actually the risk of bias tool in non-randomized studies of interventions. And then there's also Robust, which is a risk of bias tool for systematic reviews. But those are specifically risk of bias tools. Those are not geared towards critical appraisal. So what we've done with our AmStar instrument is, because we want it to be used for the assessment of a body of information, not specifically just risk of bias, we thought we'd develop it further to sort of help guide decision makers and to help you to go through the instrument, or to go through the body of literature. So the development of AmStar, the original AmStar, was developed only for RCTs, and some people are not really aware of that, and they've been using it for other areas like non-randomized studies, diagnostic tools. We did a search and found that people have been using AmStar for a lot of things. But it was originally developed for randomized controlled trials, and we had to test, retest reliability. It was built on a factor analysis, and it was published in a series of papers on our AmStar website. Been widely used, thankfully, and I'm really sort of grateful to people who do use AmStar and who do further pilot studies and validity studies. That's excellent for the instrument. So the main development or piece that we want to go through for the AmStar 2 is how it turns into more of a critical appraisal tool and sort of getting decision makers to be able to use it. We know it's usable. We've had some feedback that it is, but some of the items needed to be changed and improved. So more of the important updates for that are that it's more comprehensive. It does include non-randomized studies. It does include the risk of bias evaluation to be performed, which is the one that I just mentioned, Acrobat. And it does make an overall assessment, or domain-specific, rather than an overall score. We were really, really fortunate to get an operating grant from CIHR, which is difficult for methods development work, but we were grateful for that. So we've gone through a literature review. We had feedback from many of our users. I get emails all the time, so that's really, really great because it does help with further development. We did a survey, an international survey. We went through line-to-line review of the literature, and one of the things that we did is trying to align the yeses so that they're all positive. So people who have used AmStar will know with some of the items that I'm about to present where the differences are and how it will be a little bit more user-friendly. And again, we aligned it with the non-randomized studies of interventions risk of bias. I'm not going to present all of the items, but because there's like 15 items now, but I just thought I'd show you a couple that are really relevant. One is about PICO, and because we didn't have a PICO statement in the other one, in AmStar 1, we asked about the inclusion criteria, but we didn't ask specifically about PICO. So people will appreciate that the PICO statement, it doesn't have to be in the question, it has to be somewhere in the method, somewhere in the sections that identify what each of the 4 components of PICO, which everybody knows well, I'm sure. So if they get the population intervention comparative group and outcome, they would get a yes. And then the time frame for follow-up, people hear about the PICOs, which is study design, or PICOT, which is time. So that's an optional. So the PICO is in. We've had some comments, and people have sort of said that they're not sure it should be there, but we're confident that people will appreciate having the PICO statement. And the rest is kind of standard about the protocol. One of the things, item 3, that's a little bit different here is that they have to justify whether they've included only RCTs or non-randomized studies, or they've included both. So we now would like to justify the study design. So then the next 2 sections that I'll just show you, like I said, really briefly. This feeds into some of the methods next section. So I wanted to just give you, a heads up about the risk of bias for RCTs and non-randomized studies. So you will be able to now separate the risk of bias for the component studies. So hopefully that's a little bit helpful. And anyone who works in the non-randomized world knows about confounding and selection bias and how important they are. So the following, items are the same. There are RCTs, how they did their analysis, their weighting, heterogeneity. And the thing that I want to point out about the non-randomized for interventions is the fact, did they combine those RCTs and non-randomized studies? And if so, did they provide the data? Did they provide the data individually as well? And the fact that is really, really important for this is whether they've adjusted for confounding and given us the adjusted data, preferably. If they've only given the non-adjusted, you have to go back to the author. I mean, that's not helpful. So we need to have the adjusted for confounding rather than the raw data. And then 11 is again about the risk of bias separated. So this is, again, I won't go through all the specifics. This is all going to be on the website, this website, wamster.ca, and we're doing piloting and cognitive testing in now because we want to make sure that it fits with the MESR guidelines and that we have some interrelated reliability. So that's just one of the methods that we think AMSTAR2 will help with some of the work that's going on in sort of the new evidence or synthesis of evidence that will help. And hopefully it'll be out, well, the paper's just sort of in the midst of being produced. We've done some pilot testing, which looks pretty good. So that feeds into the next section about our patient-oriented research, because we're hoping AMSTAR to get patients involved in the development of AMSTAR as well. And they have been a little bit, but not as much as we would have liked. And that's because we didn't follow a process that hopefully everyone will begin to follow about putting patients first and involving them right up front in the development. And so now AMSTAR is one of the methods that we're hoping, or that we're using as a feed in to, begin immediately having patients at the center of all this. So some of you would have heard about patient-oriented research and SPORE. This is a CIHR initiative that is sort of a national initiative that is amazing and important, and we are really enjoying the setup of having the excellence around Canada to engage clinicians and patients and researchers together. So they said that, and I mean, we would know this from our own statistics, evidence shows that 50% of patients do not get treatments of proven effectiveness, and 25% that get it or need it are potentially harmful. And some of the statistics that we bring up through our systematic reviews, hopefully a lot of that will change with some of the new incentives that are happening around patient engagement and getting patients front and center involved in the research. So SPORE is, like I said, the National Strategy for Patient-Oriented Research by CIHR. Their mandate is by 2025, Canada will have improved health outcomes and enhanced health care and experience just by the integration of patients into research and having patient-oriented outcomes developed, patients involved in the questions, the process, everything. Anyone who's international would know that it's not just, this is not just a national initiative. Some of the other initiatives involve PCORI, which the government in the US has put multi-millions of dollars into PCORI and the research agendas. PCORI Net is a central database that they have with patients and networks. And then they have Involve in the US, so in the UK, sorry. So there's several initiatives around the world that we are kind of not following, leading hopefully, but that are ongoing at the moment. So some of the core functions around the SPORE activities locally and nationally, I guess, is built around databases like ICES, CAI-HI, real-world trials, knowledge translation, and consultation. I mean, these are just some of the initiatives that some of the SPORE centers, particularly the Ontario one, is involved with. So The national region components of SPORE, there's some initiatives that they have around, sorry, they have several sort of national initiatives around chronic diseases, which I think is still under care, primary care, etc. What I wanted to point you to is rather talk about the national, just the local Ontario, which is a support unit. So they have support units in each of the provinces, and the support unit in Ontario is called OSU. And the OSU support unit is just one of these many. So OSU is located in Mars Building in Toronto. So it's just one of the several support units that are listed across, or that are set up across the country. So our local Ontario one is very exciting because it's a combination of federal and provincial contribution, $100 million budget. It's run by the OSU Center, like I said, in the Mars Building. And they have many centers. They have board of directors. They have lots of sort of governance programs. But they have a coordinating center that then helps us with some of the projects that are happening. And I'm just going to go to this. So we have, there's OSU Centers has 12 sort of other coordinating methods centers and groups and trials groups, etc. in Ontario. So some of you may be affiliated with some of this. The one that we're affiliated, why does it keep going? Sorry. The one that we're affiliated here at our local center is the Ottawa Methods Center. So some of you would have known a little bit about some of these centers if you're located here in Ontario, and if you're in Canada, you would have been part of these national centers that I showed you. So very, very exciting. If you have any questions, feel free to pass that. So our Ontario Methods Center here locally started in 2006, and that's at the Ottawa Hospital Research Institute. And just, some of the methods around comparative effective, knowledge translation, knowledge synthesis, etc., some of the things we do. And again, that fits in. So one of the roles that we've played in Ontario, and I don't think the other SPORE units have had this engagement to this level. Ontario's been kind of, it's a, I want to say exciting or interesting or very sort of insightful thing that we've done in Ontario is to have these impact awards. And the impact awards involve patients, clinicians, researchers, everyone who's involved in SPOREs joined together. At least 3 centers, research centers, have to collaborate together. So it's a multi-center, multi-disciplinary initiative to do projects. And the impact awards came out. They were announced in June, so the letter of intent was last fall. People did up their letters of intent, and then if they went forward, they had a research proposal, went under review during the spring, and then they were announced in June. And these are the 7 in Ontario. So because it's not, the same process for each of the SPORE units across the country, not everyone would have these kind of big projects. So these are multi-million-dollar projects that the centers have joined together. So they're the 7 that got funded. If any of you were, like I said, in Ontario, you may be involved in some of these. So our role within the Ottawa Methods Group is to do, help with the methods consultation, but one of the big things that we're involved in is to continue to build the patient engagement support and partnerships. So what's patient engagement? Well, it's not tokenism. It's really meaningfully getting patients to collaborate in all that research that we did. So the AMSTAR stuff, development of the impact awards, anything that we do from now on with research should involve patients first. And so that means really actively, working with our patient groups, our patient-centered programs, our advocate groups to get them involved in the way that they sort of feel that it's, that they're really making contribution and leading the process together. We call it a co-design. So the importance of this is to make it more accountable and transparent. People say that things will change, the research questions will change if you have patients and citizens involved. Their idea, some of the outcomes that we think about. For example, I work in OMERACT with outcome measures in rheumatology, and one of the example of an outcome that patients really worked hard to get put into the core sets of outcomes is like fatigue. So, and pain, those are kind of patient-oriented outcomes. We may think of like things like joint counts or number of fractures, but they think of things that are really meaningful to their life daily, things like fatigue, anxiety, caregiver burden. So those are patient-oriented outcomes that then start to be measurements developed around them. And once the measures are developed, they get into the trials, and then they'll be able to, assess and over time be able to see if things like fatigue are improving over time or caregiver burden improving over time. So those are measures that we know or outcomes that we know, but in fact, even though you might assume that those kind of outcomes, patient-oriented outcomes, are included in the trials, they're not. So that's one of the values, and the patient engagement model. This is the CIHR framework that they came up, putting patients at the center. Well, the bottom because they feed into everything, but that they're instrumental in everything that happens. So this is the CIHR framework that they got together, and patients, 2 or 3 patients actually sit on the national scoreboard. And Patients Canada has been involved intimately into this, and there's a few other the groups that have really been sort of instrumental into the development of the patient and citizen frameworks at CIHR. So I wanted to give you I wanted to give you a few local examples. I don't know if there's questions. I'll just have a look here. You'll just let me know if you have questions. I thought I'd give you a couple of examples of the things that we've been doing at the Bruyère Research Institute around chronic diseases and others. So I seem to have lost. There we go. So one of the things that we got a grant for is to partner with the Canadian Foundation for Health Improvements, CFHI, for those of you who know, and that was really, really amazing because it brought us, because we got the funding, it helped. The whole goal was to look at the transformation of patient care and patient experience at Bruyère, but when we got this grant from CFHI, it actually brought front and center the importance of all of this to our senior leaders, and that's probably the most important thing that happened out of all of this. So this project is to look at transformation. What we did, we started with a method that I call, concept mapping, some of you know, but we started with this method of concept mapping to go through each of the groups. It's a graphical display of tools to kind of organize some of the knowledge and the relationships between the concepts. And if anyone has used cognitive mapping or concept mapping, you'll know that there's lots of kind of programs to help us do that. But what it does is it helps us to organize some of the thoughts and the knowledge that maybe what we call unwritten knowledge. Knowledge that's in your mind, but you don't actually get it out, and it hasn't come to the research level as such. So we get expert groups to brainstorm and think about central questions, and then we kind of show the relationships between those brainstorming concepts or questions, and then we're able to map them. So one area that we've looked at recently is this area of HIV, because for those of you who don't know, Canada has actually high rates of HIV and particularly in our Indigenous communities in Canada, and some people are a little bit shocked by that, but you'll see that the rates are much higher than places like Australia, New Zealand. We did a comparative study. So we took this HIV data as a chronic disease, and we started to do some of this concept mapping to involve the communities and patients, to kind of think about what are the concepts. So this was just a map, an example of the map that we came up with, that they came up with. And then you're able to sort of describe the different relationships within. So this is just an example of the concept maps that we use for this particular chronic disease. And then what we do is, you take, this is another one around gender violence. So we actually take the question, you can see how complex this can get. And we start to, really think about what are the concepts and items. So we use this as an example at Bruyère, not around HIV or gender-based violence, but you can't really give them an example of something that you're working in. You have to give them another example. But you can see the value of this, and then they weight each of the concepts. So what we did with Bruyère then is we have a team of patients and clinicians. I'm just going to go back there for a second. We went through the concept mapping, sat around, sort of see all the concepts that they come up with, listening to the patient stories, and then this is amazing, but this is just a couple of the maps that they developed. So you can see the value of having all these different pieces of paper that the patients and clinicians, and I mean, it looks very complex, but then you can actually, bring it down to this level where you're things that are quite easy to understand. So solutions around communication and improving communication, around person-centered care. So these are just some ideas that came from all these pink and yellow, concepts or ideas into something that was synthesized to be able to move forward. And sometimes it can be difficult because, if you have people in the room who may be leading or taking control, you don't know, you have to sort of watch out with the dynamics. But the one thing about the concept mapping is everybody's giving their ideas, so it's really nice for that. And then we compare the different groups. So you do a concept map for patients groups, a concept map for the families, another one for the clinicians, health care workers. So that was really interesting at Bruyère, because some of the stuff that came out were things that they wanted to move forward from a care, interventions for improving the quality of care, interventions around communication. They really wanted to drive some of those things, but we were able to focus them so that they could take these and develop them into new tools. And I'll just show you some of the things that they've developed. So the other thing that we use at Bruyère is Kaizen events. And some of you, again, it's hard when I'm not in an audience because I can't get a hands up, but some of you maybe have worked where you've run Kaizen events, which basically, not a focus group, it's a bit like the concept mapping, but you sit around to find your problem, you document the situation, you kind of visualize what the ideal situation would be, and define your measurement targets, brainstorm the solutions, and develop your Kaizen plans. So we also did some of that at Bruyère. So you can see here the boards are, some of the Kaizen work, the process that we went through. And we had 2 or 3 concept map or sort of Kaizen events throughout the last year or 2. And some of those Kaizen events now have developed what we call an admission volunteer. So we have a person who, because of that, the group came up with this idea of having someone in admissions, because they had issues with admissions. They would have someone in admissions who would actually go receive the patients in admissions and then go through the admissions process with them. So our admissions volunteer, the volunteer office has been really helpful, but that all came out of the concept mapping and the Kaizen event. And we've kind of looked at what we call always events, or this admission ambassadors, or we've kind of looked at always events and in the admission ambassador, and some of the welcoming kits have all changed. Like, it's very patient-oriented, very patient-centered. So it's kind of worked. Some of those methods have really driven what's happened there. And so the admissions, as you see, the admissions or the new admissions process, some of the patients are feeling that they feel welcomed now, that the families are treated with respect, all because one person receives them in the admission with our volunteers, receive them at the door and show them around. Otherwise, it was a little bit difficult. So the other thing that came out, you saw communications there, and because we knew from the concept mapping and Kaizen that communications is a huge issue within our environment, I don't know if other places, but I'm thinking so, because every time I hear a Kaizen event we're doing concept mapping, communications is a problem. So they wanted to improve communication. So one thing, there's lots that we can do to improve it, but one thing that we've done with the patient's input is develop this care board. So they now have this big white care board on all the patient's rooms, on the door, on the wall, and then they can, put things about the care board. One of the things that they said people never paid attention to is repeating their name so that they could understand it, or saying hello in the morning and my name is, like, people would just forget, and every time people came in introducing themselves. So just little things that sort of we take for granted that are really, really important to the patient. So this care board is now, because of the patient involvement, and this care board has been developed, and it's up on all the walls at Bruyère, and they've done some analysis to find out what people like about it, and they do like it. Hopefully they sustain it over time. There's nothing worse than spending all this time and resources to get something in place, but hopefully it can be. They're quite nice, they're big. I know it looks tiny there, but they're actually quite big, and we made the print big and the colors, so that they like it and understand. So that was one thing. So the other thing that came out of that patient-oriented process is to look at the bedside and changing always practices at the bedside. And so they do this handover or report at the bedside. That never happened at Bruyère, which is happening now. And they do hourly rounding and reports at the bedside, and they're doing training around that. They have webinars set up. Patients are involved in the direct report and handover. So that's exciting, and they have a YouTube video now that they've made around hourly rounding, and we call these like always practices or always best practices for the patients and nurses and families. So some of the, just to show that some of the sort of admissions and discharge Kaizen evaluation have really showing positive. The families are enjoying it. They feel like they learn a lot. They like being involved. And they like playing a role in being part of this. So their experience has been good so far. So this is another, it's my time. This is another family who was actually involved. I had here about the discharge Kaizen overall evaluation stuff. So this is another thing that we did. We got some money from, I think one of the liens that came, one of the liens that came from. We got some money to develop a resource path to home. So what they were saying was that, there was no package for discharges as well. So the families developed this really nice resource that they get in their admissions package, and it helps them to sort of learn who the people are. And then there's lovely, lovely discharge package, and we've now been working with. To develop been part of a randomized controlled trial with the University Network in Toronto to kind of test this discharge package. We've also been talking about the code design. It's part of our Bruyère Research telethon that we had recently. And so there's lots of exciting stuff going on there. And, I just presented sort of an overview of some of the methods that we've talked about, the evidence practice, just given the example around chronic diseases with HIV, and then care in the elderly, and considering a wide range of methods. Systematic reviews of non-randomized studies, as I said, it's going to be important for formulating some of the practices and policies around the care of the elderly and chronic diseases. Patients it's not a luxury. We're saying it's optional. It should be central to how we plan and review the care that we deliver. We can't sort of take it for granted anymore that patients are there, but they're not involved. We have, it's a process that's moving. In the next 5 to 10 years will be all about patient-centered care and patient engagement. So we've just found some of the techniques that I have described here to be really, really useful. it's sort of a simple way to be able to engage our patients. So thank you. Hopefully that was helpful.
Well, thank you very much, Bev, for speaking about transforming patient care and the ways that you've done it at Bruyère. Not only the patients, but their families becoming part of that healthcare decision-making process. No questions have come through as yet, but while we're waiting for questions to come through, I just wanted to remind everybody, some of you joined late, that this webinar will be available on demand on the Cochrane Canada's website. And the link is now on the screen, and it's under, click on Training and Events, that tab, under Webinars and Webinar Archive. That should be available probably later next week. You can also look for future webinars, training and events, by going to Cochrane Canada's website under, again, the Training and Events tab. If you've registered for today, those again who have joined late and haven't heard me mention this at the beginning, you will be sent a PDF copy of today's slides along with a short evaluation form. We would appreciate if you'd take a few minutes to complete this form, as it offers us feedback on how we're doing, as well as providing any input that helps us meet your needs as well. And for those of you who haven't registered but would like to receive a copy of today's slides, please email Alicia Degar, and there is her email address on the screen, and she'll make sure that you receive a PDF copy as well as the evaluation form. Now, we'll just check and see if there are, it looks like that there are some questions. I just want to go back here. Let's see, there's a question. How did you recruit your patients or volunteers, Bev?
Oh, excellent question. Thank you. So some of the things that's an important question for the research projects as well, not just the work that we've done at Bruyère. Bruyère, one of the easy things is that patients, I was really surprised at how much patients wanted to be part of this, and they, word of mouth helped, but sometimes it just came from the nurses on the floor would say the patients have been discussing some of the issues. You always learn from patients when they're good, of course, but when things are not going so well, they're more apt to help improve it. And that's one of the ways that we've found at Bruyère, some of the issues that had come up, the patients would tell us, and then we'd say, well, are you interested in being part of the project? And some of the patients that have been part of the process came from that. What we did for our, I don't know if you noticed there, I didn't really talk about it, but one of the initiatives is we have a new patient advisory group at Bruyère. We post an advertisement for that. People actually applied and sent us letters of why they wanted to be part of that, and then we acknowledged and sort of recruited through that way and through word of mouth. And then we've had 2 meetings, so it's been ongoing for a little under a year now. So we've had 2 meetings and it's gone very well. They really enjoy that process because they're actually feeding back, believe it or not, even on a new instrument that we're developing around satisfaction and patient experience. So they've been intimately involved as much as they can into the development. They haven't been as such working with us at the Research Institute yet, but we're starting that initiative as well. We're having a new patient advisory at the Research Institute. So recruitment can come through many ways, but yeah, word of mouth and the organizations and patients that are known within and out of, who have been in and out of the hospital.
Thank you, Bev. There's another question. Are these tools being used to engage patients in basic science research?
Oh, great question. That's possible. The only time that I have where we've used a little bit of this has been in a session that we did discussing like stem cell stuff, but no, we haven't really. It could easily be used to do that because, you know, some of the basic science researchers would come up with the same concept. So it can definitely be used to recruit or to sit and go through. As long as you had the patients separate from the clinicians, that would make it easy to use, except for the Kaizen event, they're gathered. But when you're using the concept mapping, we tend to have the expert group separate. So you can definitely use this in basic science.
And that would also apply, I guess, for the clinical trials research too?
Yeah.
I guess that's what you were really speaking about. Yeah.
Yeah.
Okay. Because this question was asked, you know, sort of twice. I guess it was a clarification about basic science research as well as like in clinical trials specifically.
Yeah.
If anybody's got any more questions, please feel free to type them into the chat box. I don't see any questions coming through at all. Yet. Is there anything else you'd like to add at all? I think you've actually pretty well covered everything, Bev, in actually record time too.
Sorry, did I go too fast?
No, you didn't.
I tend to speak quickly. But the slides are available, and you know, there's always an email. There is an email on the slide. I'm always happy to answer questions. Just the development of AmStar will be on our website. The work that we're doing with Bruyère is going to be on our Bruyère Research website, so people can actually, you know, we have a sort of process in place around rapid reviews and clinical questions, so that's going to be part of that. And
okay, and if anybody's got any questions, certainly for Bev, or if you would like, you know, to have a question sent to me as well, our emails are up on the screen right now. So if something comes up, please don't hesitate to contact us. So again, thank you very much, Bev, for presenting, and thank you for all of you who have joined us for today's webinar. And please join us again in the future for Cochrane Canada webinars. We look forward to seeing you again.